I'm very excited to introduce the next speaker, whom I've gotten to know over the last year and a half. And that's Dr. Trina Histon, who is with the Kaiser Permanente system. And as a reminder, we'll do a Q&A session at the end of her presentation. And if you have questions and answers, please put them in the Q&A tab in your screen. We'd be happy to have Dr. Histon answer them. Trina is a senior principal consultant in prevention, wellness, and digital health at Kaiser Permanente's Care Management Institute. She's built an extensive career addressing prevention, well-being, behavioral health change, and emotional health, translating evidence into practice in healthcare in both Ireland, as you'll figure out as soon as she starts to speak, and the U.S. She's been working in the digital space since 2010. I think she was in 8th grade then. But she's currently the co-lead for the Project Kamai of Kaiser Permanente, and she's really the principal architect behind the digital prescription system of Kaiser Permanente, which has done over 150,000 prescriptions. And their system, in our opinion, and we've looked at many systems through the U.S., is probably the most comprehensive system that we've seen in terms of reach and what it offers and how it's integrated into the workflow. So we really hope you enjoy this presentation. And with that, I'm going to turn it over to Dr. Trina Histon. Welcome.
Thank you very much, Bruce. It's an honor to be here, and great session so far. So I hope I can match the brilliance that came before me. You know, I was listening to Monica at about 6:15 a.m. California time, and I was struck by what I'll say is she was giving the digital behavioral health version of the Gettysburg Address. Let's hope it won't take 20 years for us to realize the value of digital health, and also struck by her framing around the intersection of science, policy, regulatory environment, and practice. So that's certainly where I feel I spend my time. So that really resonated. And of course, a fantastic panel on frameworks and evidence. You couldn't see me, but my head was nodding the entire morning, as it was here on the West Coast. So great to be here. And I will bring you through sort of the real world experience of deploying a digital mental health ecosystem, which we started in 2017. And so what we'll touch on today is I'll give you a little bit of context for our national mental health and wellness strategy, go a little bit into our why, defining the problem we wanted to solve, walk through how we chose apps in 2017, how we've evolved that process, really show you how we've embedded these tools into workflows, and then share some of our early learnings, because I still feel with humility we're still early on our journey. So a little bit about Kaiser Permanente, and I'll draw your attention to the right-hand side of the slide here where you see the 150,000 digital prescriptions. That is what I'm here to talk to you about today, but we exist in a much broader integrated delivery system, 92 billion in operating revenue. We have 12.6 million members. That's what we call folks who purchase our care, over 20,000 doctors, over 700 medical offices, almost 40 hospitals. And so a broad integrated system, and one of the largest and oldest in the US. And here you'll see some of the highline messages from our digital, our mental health strategy. So, you know, we've heard about the shortage of staffing. We have a pipeline where Kaiser Permanente staff, if they want to become a therapist at the master's level or psychologist at the PhD level, we have a pathway for them that we will actually subsidize and spend the dollars to bring them into that workforce. You'll also see in the left-hand side, we've also made 2 of the 6 apps I'll speak to available as a self-care option, so you don't have to be part of a plan of care. You can receive Calm or My Strength via that. So that just kind of gives you a snapshot on sort of what's going on in the mental health writ large and where we fit in. So I want to start just getting a sense from all of you. You know, are you currently deploying these kinds of tools in your system? Are you just starting to think about it, but you haven't necessarily made any movement? You know, you're not yet, or you want to, but you're just not sure. I'd be curious to see you know, what your thoughts are on this. So if you wouldn't mind choosing your option. And I'm seeing some of the numbers come in here, so I'll wait until I think when I hit next, the answer should come up. If I did that right, Vinfen team, you can move me back a slide if I didn't, and actually I have a lot going on my screen here. So yeah, so 50% of you are fabulous, and then 25% of you are not sure, and then 12% aren't, and 12% are just thinking about it. So I think we've got a good mix. So those of you that are, I would be really curious in the Q&A what's resonating with you, and maybe you solve for some of the things we're still trying to noodle our way through. So thank you for that. So getting to our why. Back in 2017, when we looked at 4 of our markets, so we have 8 markets, 80% of our business footprint is in California, and we were looking at our data, and we were seeing about 20 to 25% of patients who were in specialty behavioral health seeing a therapist. Actually, when we did an intake, were subclinical in nature, so they didn't necessarily meet a diagnostic threshold for depression or anxiety. And so at the time, we didn't really have a systematic way to offer members who were subclinical tools that might support them sort of getting back more fully in their lives, because they were determining, as members, that they were in a crisis and they wanted help. And then, the clinical dimension was that they didn't necessarily meet the diagnostic threshold, but they were still suffering. So we wanted to understand, might we be able to meet needs in different ways? So that was the original problem that we wanted to solve for. And I think we've evolved quite a bit since then over the years. So this is a slide that really kind of shows kind of one door into care. Therapy and medication are pretty sticky defaults for how we've supported people's mental health journeys, and indeed those who access care. And the thought bubbles you see are actually things we heard from members. So when we did a deeper dive, we were discovering in that subclinical space or mild symptomology, it was really depression, symptoms and emotions related to depression, anxiety, and adjustment disorder were really prevalent in that patient population. So we really wanted to explore, how might we create more opportunities to receive support to help somebody again get more fully back in their lives. So I am a health psychologist by background, and I've been embedded with our design consultancy at Kaiser Permanente for several years now. And really leveraging human-centered design to me has been a difference maker in how we've been able to build and scale this, and really receive the clinician adoption and frankly the member adoption of these tools as well. So human-centered design is a problem-solving, empathy-based methodology, and we really go deep into your user experience. Your users in our instance are clinicians on one side of the coin, and on the other side of the coin are members. And so how do we make it easy for both groups to make a referral on the clinical side and receive that referral to a solution that can help somebody? So a little bit about the methodology. This is sort of the process that we go through. We start with the focus, so thinking about the problem we're trying to solve, deeply in the understand phase, looking at the evidence base, talking to subject matter experts internally, externally, including some of the folks who were on the panel prior, that I'm a huge fan of. And then we really move through building and testing and prototyping, getting then to scale and then getting to sustain. And this looks linear on paper. The reality is we move back and forth on some of those. So for the adult deployment, which is pretty robust and scaled now, we're sort of in that sustain phase, but we're still building out kind of more final state data infrastructure. And I'll speak more to that in a bit. Where I'm spending my days these days is actually within youth mental health from the ages of 12 to 24. And that's a very different ecosystem build out, which maybe at a future date, Bruce, I can come back and speak to there. But today we're going to focus on the adults. So going a little more deeply into the human-centered design, I really love this image because I think it shows the complexity of being human. The dimensions of thinking, feeling, saying, or doing. We know as humans that we're predictably irrational in one way, and we can think one thing and say another and do the complete 360 of what we're thinking and saying. And so what we want to be able to do is lean into all of those ways of being as being a human being, and try and kind of elicit what might be going on, what might be behind something you're saying or behavior you're doing, and can we dig a little bit deeper to do that? So that's kind of part of the toolbox of HCD, and my experience has been incredibly powerful. So how does that look in the real world? So this is some images, again, pre-pandemic, when we could be at our medical office buildings, or we could go into members' homes and do interviews there. Maintaining curiosity, again, with the rigor, with an interview guide, but being open-ended in questions. Maybe, we're pulling out boxes of Crayola crayons, and people are like, I haven't used those since I was in school. But getting people to draw, what does a good day look like for you? And then you can probe on what's in the picture, or what's a bad day, and then probe on that. So it really is a wonderful way to bring the richness of the human experience forward, so then it can be quantified. So these are some of the things that the tools we use in the toolbox to get people to do a preference set. Would you like to have a therapy session by phone? Of course, we all know in the pandemic we've pivoted to that. And would that be your top preference, or would you rather face to face? And some of the drivers to phone-based care at that time were, it was without a copay, so that had appeal. Just to kind of give a historical pre-pandemic reference, which feels like a long time ago now. So that was sort of the work we did. We interviewed 99 people, 38 members, and then the rest were staff in various care settings that you'll see here. We were very curious to see where might these tools best fit. So we looked at depression care, which is collaborative care is the sort of rebranded name. We were with kind of triage / care navigator roles. So that's like a 30-minute phone call with a therapist to really determine, how are you doing clinically, and then where's your best next step to go to, whether that's, going to psychiatry to see a psychiatrist or a therapist. We also wanted to understand the primary care experience, because we know a lot of the demand, even though you can self-refer in our system, is from your primary care clinician, and then understanding psychiatry and therapist experience in specialty behavioral health, but also within health coaches, because we have those in our system and they talk to a lot of members, with the stress programming. And so what tools might we have in our toolbox that they could use? So that's sort of all the different care settings we're fully deployed in today. What we were then doing from that field work is synthesizing all the themes that we learned from our members and from our clinicians and from our subject matter experts, and really kind of iterating on the main themes. And so we came up with a couple of different ones that are key, and they won't be a big surprise to you, because they really are the cornerstone of delivering good care. Trust is a prerequisite. Here you'll see the quote: somebody really wanted someone they respected that had expertise to really help them understand, what their behavior, was stemming from, and help guide moving forward on that. So that was sort of one cornerstone of what we were hearing. And then the other thing was interesting around framing. So if therapy and medication are very sticky defaults, then how might we create a different framing for different opportunities to receive care? And so in our system, we also do a lot of groups. And so talking about them more as a workshop versus a group, because I think there was a fear, and we heard this from members, that you got to sit in a room with strangers and talk about your deepest, darkest fears. And that's not really what happens in group, but that's the perception. So can we frame things so there are different opportunities for people? So from all of those, we really leaned into 4 areas of opportunity for design research, which is sort of what our ecosystem build is. One is setting expectations to create new opportunities. So how might something like a digital mental health app help with your plan of care? The second is really empowering members to help themselves. And we've really heard this in all of the pinging the network we've done qualitatively and quantitatively. This is a really sort of loud and clear that members really like having something in their pocket on their phone that now is their go-to coping technique when they know that intense emotion comes back. Now they know what it is and what to do. And so that really is helpful in empowering them to navigate through that moment. And obviously, if they need to come and see us and it's an ongoing issue, that's available to them. But really, that empowerment of educating, normalizing, and destigmatizing what's going on has been a game changer. Again, building on the trust that members have with providers, and then making the right support easily accessible to members when they need it most. And I'll talk a little bit about that when I show you our EMR deployment and all the different ways we've been testing. So where we ended up, so this is a depiction of our ecosystem, and I'm going to spend time talking about that top line there. You see the clinical delivery pathways, because that's sort of where I spend my time. But I did reference we also have self-care, and I will tell you we had planned to stand that up in 2020. And when the pandemic hit, we were able to turn the dial all the way up to 10, which was good. And we had sort of annual projections for maybe how many people might avail of Calm and My Strength as 2 of the 6. We met that in 4 days. So the need was there, obviously, early in the pandemic, a lot of pandemic-related distress on top of what we were already seeing, in specialty behavioral health. So within the ecosystem, within our EMR, so Epic is our platform, it's KP Health Connect is what we call it. And it looks a little different in each of our geographies. So we were able to flex the EMR tools to make it fit with the workflow of the specific care setting, whether you're a therapist, psychiatrist, health coach, primary care doctor, we really wanted to lean in and make that easy. But the same endpoint is you have access to the apps. And then we also built out a new suite of content, articles and audio, because we were hearing from therapists and members that what we had before was very clinically framed. What is depression? What is anxiety? We're a healthcare system, so not surprisingly, we will frame it in a clinical way. But they really wanted content set in life context. So now we have relationship stress or parenting stress, and really, putting it in a more consumable frame. I will say, we've really iterated with our clinicians. We started out with about 26 in two of our markets, Southern Cal and Northwest, which is sort of Oregon, Southern Washington, and really iterated on to make it the fewest number of clicks possible. And what I will say is, we're looking at the adoption rate, and we were tracking how many clinicians that we trained have ever referred to a solution, and that's 72%. And mightn't be the perfect comparison, but when you see what's happening in Germany with the DIGA rollout there, where they have full end-to-end frameworks, payment models, you name it, they have it. And the last data I saw was about 2% of doctors are referring or prescribing solutions in the DIGA model, and they have a couple of mental health apps in there. And then, the Gilbody study from the NHS had about 19%, and I know that study had some methodological issues that the panel before me could explain to you in more detail than I can. So we feel like 72% is a very healthy adoption rate. I wouldn't necessarily expect 100%, just given an app is not for everybody, and not all therapists are sort of in those care pathways that may have an app as part of their workflow. So it really is around the suitability and making that match. So we're changing how we track that metric, and I'll talk about that when we get to some of the engagement pieces of my talk. So that's sort of the ecosystem. Then really showing you the current suite of apps. We've actually added more recently Ginger for emotional support coaching for that dimension, as part of the ability to make the referrals. So we're leveraging the architecture we built for Kamai is what we call it internally, which is Greek for the word grounded, but we're leveraging the ecosystem build. So it's easy to add more apps into the ecosystem. And that's the intent here, that we build it and then we can add. And then in app lifecycle management, we can also take some out if that's needed. So we have 3 mindfulness meditation, 3 cognitive behavioral therapy apps. We chose them for the user experience is quite different in all of them. And what's been interesting in the journey is Headspace is now with Ginger as Headspace Health. Will is now part of Rethink. My Strength went through a takeover with Livongo and now is part of Teladoc. And then SilverCloud has recently joined the Amwell family, and Thrive is part of Pair. So we've gone through what I call digital Pac-Man, where companies are merging or partnering or being just taken over by other larger entities, and then navigating that kind of new partner space. So that's always kind of a work in progress. So, you want to make sure you're choosing good partners because you'll be on a long journey with them, and things will flex and change. So the adaptation piece that Monica referenced is very important. So they're the 6 that we have right now. But I want to anchor us in, who are we thinking about when we bring all of these solutions to bear? So this is Diane, who's a member in our Northwest region. It's not her real name or not a real image, but her quote is all of hers. And I won't kind of read it line by line, but what I want to point out for you is she was going through tremendous, this is pre-pandemic, life changes, like really stressful life changes. And as part of her plan of care with the therapist, they felt it would be useful to also give her an app as something to help her kind of navigate in between sessions and to leverage the tools. And so here you'll see that she's been doing that. So, when she starts to feel overwhelmed during her day, instead of maybe doing behaviors that might later on add to the stress because she wasn't sort of engaging in the work that she knows she's wanted to do, she was able to use the app to manage through that intense emotion, get on with her day, and still recognize the issues were still there, but that she could deal with them better. And that was sort of her big gestalt from using the app. And so that is sort of an example of how these tools can help. And I have many, many more stories that we have from our members about how these tools for help. So we track the qual and the quant. So back in 2017, it's like, how did we choose apps? So back then, it feels like a long time ago now, we sort of looked at 3 dimensions. And I'll thank John Torres, who may or may not be still with us, but the work that he's done with the American Psychiatric Association, with sort of the guide that they've developed on how do you choose an app, like what are the dimensions you need to think about. That was instrumental for us back then. And then we looked at the published literature. There was some nice papers out of Australia about the different dimensions that you can think about when you're looking at an app. We started with this ecosystem with mindfulness-based meditation and cognitive behavioral therapy because we felt the evidence base was stronger in those dimensions. And I think we heard from the panel this morning that the effect sizes are modest, so we accept that, but we still feel like they add benefit, and there's enough studies, certainly with CBT, over 100 RCTs showing the benefit of it in all modalities. It is effective whether it's on the phone, online, face-to-face, or in a group. And then I think the early outcomes from these companies were important to us, and they've been growing and growing in their developing their science muscles, which we both need and want. And then I think the other game changer was the engagement and user experience. The panel this morning talked about, if you're not going to use the tool, it just stays a really nice tool that nobody uses and you don't see the benefits. So the user experience is very, very important. We've all seen examples of really strong scientific programs or apps, and then very low use rates because maybe the user experience might feel a little bit clunky. So that's kind of where we started. Where we are today is we have a 7-layer, I think it's about 78 items now, rubric that covers all of these dimensions that you'll see. So the evidence base is very important. Obviously, product reliability. If the app keeps crashing, that is not a good user experience. So really understanding, how often an app is able to be up and live and what their kind of remediation plan if anything happens. Engagement elements, I'll go a little deeper into that one dimension in a little bit. The company reputation, it's important that you're partnering with the company that will match to your mission, vision, values, and what you're trying to accomplish together. And they will have their own priorities too as a business, and we kind of respect that. We want them to stay around. We did work with an early company that sadly went out of business, and it was testing really well. So we've gone through the pain of that too. Also looking at maintenance, are they refreshing the solution? Are they learning from their user base, and how are they, making that different? The pricing models. So, we are moving toward value-based payment. I'll speak about that later on. And then integration and data security, super important. We have a very robust technical risk office review that we bring these apps through if we're going to go through final contracting with them. And we've 3 of the 6 now brought through the entire process. And again, I'll touch on that a little bit later. And it is necessarily arduous. Really thinking about privacy and security and data use. We are a highly regulated industry, and historically, healthcare is a very risk-averse industry. So to move into this space, we want to make sure what we're bringing to our members is providing value for them. So that's sort of the top line framework we have. This gives you a little more detail with some examples of the scoring key. And, we can weight things differently. So the evidence-based engagement and security, we can weight that more, and then each app will have a final score, and we can kind of talk through, okay, how is it testing, as well as our clinician experience and our user experience. So we really can bring this into the room and have really robust discussions on how apps are doing. And so that's just giving you, again, an example. I think it might have been Paul, or it might have been Steve, that referenced the Digital Therapeutic Alliance earlier. I actually serve on their payer accelerator board, and they did release a new guide this week for healthcare decision makers on kind of digital therapeutics writ large, and the various types of decision making you consider when you're deciding to partner with an app. And I highly recommend having a look at that. It is very robust and really designed for decision makers for how do you choose an app, and goes into all the dimensions, much of which is here. It was an honor to be part of helping shape that, and they really did a nice job of getting diverse perspectives into it. So I'll go a little deeper into the engagement elements so you can see some of the things we think about. So back in 2017, these apps were available in English. And if any of you are in health systems like ours, we have a very diverse member base. So we want to make sure we're reflecting multiple languages. So we're not sort of creating another digital divide by just using apps that are only available in the English language. So again, in partnership and influencing product roadmaps with these companies, they are available in multiple languages, and that's been over the time we've been working with them. Only a couple of them started out with multiple languages day one. We also want to look at somebody's learning style, their levels of capabilities. Do they like video? Do they like being able to input some text? Do they like to read? Do they like the audio? So mixing all those modalities, making sure the solution is comprehensive. Looking at some of our solutions have coaches, some don't, because some people want that accountability and support, and then some don't. And then obviously being mobile first is table stakes now, because everybody is kind of working with their mobile phone, but also thinking about, if people are on restrictive data plans or their shared phone in a family, are we able to use some of these apps offline? Because that will determine a match a therapist might make if somebody's in a poor Wi-Fi signal or a poor cell reception. Can they download content on Wi-Fi and then be able to get through the tools offline? So all of those things are very, very important. And, I'll touch upon the evidence base, and I knew the panel this morning would go much deeper into this, so I chose to take out the slides I had. I had many on the evidence base, but always tracking the science. And, I think we recognize that the literature does indicate overall efficacy of CBT and mindfulness meditation in all modalities, and the effect sizes are modest. I think the journey ahead is, how does it work in the real world? And we're knee deep in that right now, or maybe even more than knee deep, in trying to understand that and optimize that. So I just wanted to touch on that without belaboring it, because I knew the panel this morning would do that. What I will say is, apps alone will not get you where you need to go. You have to consider the context in which they're deployed. So ice cream kept to perfect conditions can be really tasty when you get to it, but if it's not held in a perfect condition, it'll melt, right? It'll get messy. So, really we think about the context of how we deploy within our ecosystem as well. So how does it work in the real world? So remind you again of, this is sort of our visual of what we're building. So anybody in our system can make a referral, and they should be able to do it easily via the EMR as part of their flow of care. They shouldn't have to go out anywhere special and then come back in and do anything. So how does that work? So what we've been learning that works best, so these are some of our best practices. Obviously, during the assessment, the clinician's listening for what's going on with the member, what's sort of the nature and the duration of the challenges they're experiencing, what are their symptoms, and so if sleep disturbance is a big piece of that, they might be thinking of a mindfulness meditation app that has sort of the sleep component, like the sleep stories or sleep casts, whatever, built out. Then they'll give a very specific recommendation for what the skill is they'd like somebody to start with in the app. So somebody's not, who may be low mood, low energy, going into an app that has a lot of programming, which is great, but they might not have a starting point in their mind. So being specific is important. And then they're documenting that in the EMR, and we can do it via text, which is super popular, to just get the text on your phone, and then you kind of go through the flow of the app and go through the Kaiser door, because we provide all of these tools at no cost to our members. And so it ensures the app knows, okay, this is a Kaiser Permanente member coming in, and they're able to kind of open their door, and then the member can have the experience. Then we have that the follow-up visit, therapists are checking back, how did that go, what worked for you, and where can we go to next within the app. Sometimes they may start with the mindfulness meditation app. I would say ecosystem wide, we're probably at a 60-40 split, where 60% of the referrals are from mindfulness apps and the 40% are for CBT. And sometimes a therapist will start with the mindfulness app, and then when somebody's starting to feel better and they're ready to do the work of CBT, then they'll layer in a CBT app. And we recognize that CBT is work, and it has kind of a cognitive burden to it. So we want to make sure we're calibrating that referral to where somebody's ready to sort of take that next step. So this is a visual of what it looks like in our EMR. On the right-hand side, those of you who have, Epic as a platform, that should look very familiar. This may be hard to see. So I'll kind of walk you through the flow, and I hope I can see it myself. So first is, having that app choice, and that's done in a shared decision-making way with the member. Often we might, show them the choice of apps, and then say which one is kind of calling to you right now that you might feel will be helpful. And then you can make that referral either via text, via secure message, or all the way to a letter. If somebody wants a letter with the referral methods in there, we can do that. And then because we've built it and it's basically a copy and paste where we've pre-populated all the instructions. The clinician can then paste that, the progress note in the after visit summary in multiple places without having to type a whole lot more new stuff. So we really worked hard to iterate on that to make it easy and for the clinician to refer. So if you think about what's happening then in the office visit, pre-pandemic, we had these very, very popular tear pads, which we've now made virtual in the pandemic. And, clinicians really love them and members really love them. And you kind of felt like you were walking out with a prescription. Now, I know, therapists kind of prescribe, MDs and nurse practitioners, there's certain licensure for that. But when you talk to members, they use the P word. So I'm sort of using it liberally there with through the member lens. But you'll see with the tear pads for members, a therapist can tick on, with calm, we want you to start with, the sleep. And then the white box you see below, that is, I'd like you to do this 3 times a week, meditate for 10 minutes or whatever. So they can be very specific about how often and for how many minutes that you do something. And then sometimes in the context of the visit, they have choices. So, okay, which app again had a coach for CBT? And so we wanted to build out app guides that were super easy for them to see, which ones you could download content on, which ones, had a coach like SilverCloud, which ones are more video-based like Thrive, which one had, a lot of programming, beyond CBT like DBT and acceptance commitment therapy with MyStrength. And so really easy to help them look at that and make a choice. And that's been super popular, with our deployment to have those quick and easy guides. We also have a app map recommendation guide, which takes symptoms and maps them across all the apps. So again, if you're quickly wanting to find something that has content, for parenting, for example, then okay, that's Will. So it's just easy to get what you need quickly in the context of a visit, because there's a lot happening in a visit. I talked about the articles. Basically, we have all of the content on kp.org is available to anybody in the world, actually. But all of these tools that you see, like stress or mindfulness, can be also given via EMR. So we just basically mirrored it within a user experience that is more typical of a website. Sort of ongoing needs as well. The pandemic then came, and we'd already planned to scale and expand. We were in 3, about to go into 4 markets. In fact, my last trip in 2020 was out to DC area, where we were launching as our third, and then we rapidly had to scale in the pandemic. So I'm just providing a quote here from Dr. Tim Ho. Dr. Ho is a leader in Southern California, and I won't sort of read every single word here, but we made a rapid pivot to telehealth, and Monica talked about it earlier. We were probably about 30 to 40% telehealth prior to the pandemic, and within a month we were about 95%. So what was lost in that, though, was sort of the ability to really show empathy by leaning into listen and making eye contact. That was more challenging to do, either where I am with you now looking into a camera, or just on a phone call. And so we were hearing from ophthalmologists were reaching out to me saying, can we get these tools in ophthalmology, because patients are really distressed with COVID, and I really want to be able to give them something. And so we literally turned the dial on for all care settings, and rapidly expanded and scaled with Common MyStrength in those settings to be able to give them access, because they really need to be able to do that. And I think where we are now is there's really a value of being able to put digital tools into virtual channels. There's more of an appetite, while I would think we've innovated a decade's worth in the year of 2020 alone. Is it full-on transformation? I probably am somewhere between what Monica said, between adaptation and transformation in our experience. And and it's hard and it's challenging to change, but we need to. It's important to do that. So that was sort of what was happening. I just want to give you some perspective of the scaling. So we started this work with 26 clinicians who really were fabulous partners and helped us go really deep. We'd low numbers of referrals. That was by design. We had design constraints. You only have 25 licenses for each app, because we really wanted to see and understand their choice architecture, then codify those learnings of how they were making a match, and then iterate in all the tools. So that was by design. And then, by May 2020, we've gone everywhere in our system, and made about 45,000 referrals, and then cut to today. When I'm looking at May of 2022, we're tracking about 13 to 15,000 referrals a month. We've changed how we're calculating the clinician referral rate. So we have pretty steady state, over 1,000 clinicians every month making that number of referrals, and we've just passed our 358,000 referrals. So every day that tickler goes up and up. So that just kind of gives you a sense of the scale and spread, and the fortuitous nature of we'd really stress tested everything so we could then turn it all the way up in the pandemic. So it felt good to be able to be part of our pandemic response and really support our members and our clinicians navigate through that very hard time in 2020 and 2021. We're not done with it yet, as we know, but hopefully we're on the shorter tail of it. So part of the system is keeping it going. So it's not a one and done sort of type training scenario. It's how do you build out those digital mental health competencies, and bringing new workforce members in, and how do we get them up to a level of competency of making referrals. So we have a couple of different ways that we do that. So within specialty behavioral health, that group uses a lot of SharePoint. So we have a SharePoint site built out by each market, and so if somebody wants to go a little deeper on each of the apps, they can do that, and the published literature on the apps are there as well, and all the tools and tips and tricks live there, and then any new information we have, we launch there. In our sort of MD primary care non-specialty behavioral health environment, clinical library is where our docs go for up-to-date and guidelines, etc., and we built out job aids and an 8-minute training for primary care for how to make those referrals, but also what might you think about as who might be a good match for which app. And then ongoing, we have an on-demand training for that a manager can assign, say if a new therapist coming into our system, that they can get up to speed and begin referring as well. So we've been thinking about how to do sort of all of that. So what have we been learning? We've sort of pinged the network several times, 2018, 2019, 2020, 2021. We just did another member survey earlier this year. And I'm presenting sort of the findings that are quite consistent across all the timescales, even in the pandemic. So the personalization of the referral is key. And 86% of members said they were willing to try an app because their therapist had recommended or their clinician had recommended it. So again, that referral alone and that warm handoff is very, very important. We were also hearing, the specificity of where I start in the app is very important. So there's kind of no confusion, and also giving a sense of frequency of use. So again, really, truly like a prescription, that really helps somebody get a good place to start. And then their own curiosity, they can follow that for other content areas in an app that they might want to address. Also looking at the relevance. So, in the early days, we might have had a poor match where the context setting wasn't very deep, and the member was like, I'm not sure why they gave me this. So we wanted to kind of dial down that experience and really make it a good match. So, you're having sleep issues, or, you've talked about, challenges about being assertive in your relationships. And so Thrive has some really nice assertiveness modules in their CBT experience. So it would be very real when you opened it. Okay, that's why they gave this to me. And then expectation setting, though, how the app will help. So, they're not a panacea. They're part of plan of care. We consider them as an augment or hybrid, as John referenced earlier. And then the other thing we found powerful is when the clinician relates their own experiences with using them. I think we've all been a little distressed with this pandemic in our own ways. I think it's a rare individual that has kind of sailed through this without having some moments of pause, and we know our workforce has just been tremendous at being sort of at the wheel every day, and they're human too. So really looking at how their experiences in using these apps can make that referral sticky. And then members also might want to choose different apps, so they like it when they're given a choice in the discussion in a shared decision making kind of way. So they're kind of some of the key things to make it come to life in the real world. I would say we continue to have many cycles of learning, because we are a learning organization, and really thinking about I showed you earlier that continuum all the way to sustain, but with the data infrastructure, with the referral process, all of those things we're constantly tweaking and looking at how can we make that even better. But I want to touch on engagement because the panel this morning talked about it. We think about it. I think about it probably more than I probably need to. But I'm just curious about, we look at the published literature, and this is a very recent study looking at kind of broader health apps, if you will. I think it was a pooling of about 389 studies that just came out, I think this month, if not late April. But what increases engagement and retention in apps? Well, having a feedback loop, very important to keep somebody engaged. How are you doing? What's going on? And it doesn't have to be necessarily a coach or another person making a reflection. It can be kind of built into the user experience. Having those reminders and notifications to, hey, you haven't checked in a while. How are things going? In-app support from peers or coaches, and then they found, again, incentives or compensation was a key stickiness factor. That's certainly not what we're using in our deployment, but that's what the literature says. And then poor engagement, lack of support, features, technical difficulties, and usefulness of the app. So I have a polling question here, and if you were really paying attention earlier this morning, you will have heard the answer. So on average, how many days does a user engage with health-related apps? Just curious, give you a few seconds to make your choices. And I think if I hit the next slide, we'll see the results. So I'm seeing 100% at 10 days. So I'll give it another few seconds. And Vinfen team, if we need to go back to the previous slide, please do that. But there we go. Let me just scroll down here so I can see all of it. So the answer is actually 4 days, 4.1 days to be precise. So that's what we see again more in the health-related apps that we see. What I will say is that data suggests that on average we spend about 4 hours a day on our phones. So it is a great way and a great mechanism to get something good in somebody's hands, in theory. And then 4.1 days is how long people engage. And so really thinking about that sort of, we think about dose response and medication. I guess I think about use response, but it's nuanced. That's what we're learning. So here is a paper that John referenced earlier about the 15-day retention rate in digital mental health. At 15 days is 3.9, at 30 day is 3.3. I kind of won't belabor the point, but is that a long enough tail for somebody to derive benefit? So in our deployment, we sort of think of engagement in multiple ways because there is no standard definition. And it could be, I kind of think about it along the FIT model. So is it the frequency, the intensity, the time, or the type of engagement in the app? And I point out what each of those might look like there, from logins to specific content. In the CBT apps, obviously, we have PHQ-9, so we can get pre and post, and we can look for response remission, the standard clinical benchmarks that we look for, and also looking at improvement, which is a 6-point drop in PHQ-9 score. So that's sort of the milieu of the data we're looking at, and we do get de-identified aggregates. So I kind of want to point that out. We're on a journey to get MRN level, and I'll talk a little bit more about that in a moment. But on the right-hand side, I'm kind of showing you the depiction of what we see as different arcs of engagement. And so we are actually seeing members use these apps in different ways. We have some folks in there every day. It's kind of their touchstone, their centering moment. They will go in there and practice a technique or use a tool. We have other folks who might use it in spurts. So something's gone on in their life, they're using the tools, and then they're getting on with their life. We have others who will use it till they get better, and then they go. And then we have others who will, come in over time and go away and come back and go away and come back. So we know by day 15, 3.9% are still using an app. Our work with members, our data and our surveys show that if people are experiencing symptom relief, they may feel like they don't need this app any longer. So that's something we need to, both address in further studies and further probing. But we've been hearing that sort of from member segments. We also see that people really derive a lot of the value within the first month of using the tool. And so I would also say, you'll see there in our deployment, mindfulness meditation has higher engagement at about 56% compared to CBT. So we might have about 23 to 25% are using a CBT app. And then we tend to see a longer tail in our engagement as well. So people are staying longer than that 15 days. We're seeing 30-day. In fact, we even see up to a year's use of working the app. So it's not a one size fits all. And I think the work that Pat Ariane was referenced earlier will be very important in helping us understand those user segments and then making a match of an app to that user segment. So it is not a one size fits all. And we're very curious to see when we were able to do more data analytics, what those patterns look like. We are looking at PHQ-9. Here I have collapsed all of the CBT 3 apps together and their data. You'll see that light lilac was sort of our milder symptomology, but the reality is these tools are being used across the care continuum and value is being derived across the care continuum. So folks who are moderately severe are in a comprehensive plan of care, therapists, likely medication, and psychiatrists, and they are still also finding value. So caveat here is we don't have a control group and we only have data for those who do a pre and post. So the apps are different in how well they're able to capture that post PHQ-9. I certainly want to see a much healthier number doing pre and post. You'll see it ranges from 14% getting a post to 52% getting a post. So I'd like that to be higher. And then we also track worsening because we want to make sure signal-wise that people are getting what they need, and directionally that's sort of what we would expect as well. Hard to isolate the effect of the app from the plan of care. So that's the reality of that. The other thing we do is really pinging where our members are finding use. So we do surveys. This is probably our 4th survey. We'll caveat emptor, it's a small response rate, not where I'd like it to be as a researcher, but pretty consistent across all the years we've been doing this in terms of where they're finding value. So stress, anxiety, coping techniques, for things for low mood, for focus, and for sleep. They're sort of the main areas that people are finding the apps useful for them as part of their plan of care. And we want to be able to go much more granularly and look at that. But kind of what makes the process sticky in real life? These are some of our best practices. So talking through the app pamphlet now on the phone and doing a demo. We've got QR codes so they're able to see, grab the app and go right in the Kaiser door. Really being specific about when will you use this or when will you download this. Talking about the content and how often to use it. Also using motivational interviewing to really probe at, is this a good fit for somebody right now where they're at in their care plan? And then being able to send the app instructions very quickly via text, usually is the most popular. And we also found that the earlier in the session the app is introduced, the better the land. So they're all some of the best practices that we have. So what's next for us? We've been working with de-identified aggregate data from the app companies. As part of the deeper work with Technical Risk Office Review, we've been developing simple account linkage, which will really enable us to say, okay, Peter Smith is a KP member and they're getting MyStrength. And then they're able to map through and get MyStrength, and we know, who that member is. So we're working on the member level data. So then we can map that data to a plan of care and be able to do a lot more research. We have research entities in each of our Kaiser geographies. Susan referenced Arnie Beck, who's a cherished colleague in KP Colorado, and they are ready to go look at all this data and see where these apps are helping. And members have a very clear opt-in or out of that too, by the way. The refreshed privacy policy, when you open the app, it's clear what you're opting in and out to. Really looking at our app lifecycle management. So will all apps stay forever? Perhaps not. So what's serving our needs and how do we do that? Embedding these tools in our feedback-informed care and measurement-based care models. That's happening more and more, where we can decant some of the tools in the app with the feedback-informed care model. Value-based contracting. So not just value for, are you activating, are you engaging, are you improving, but also patient satisfaction, because in the value-based payment, we also want to make sure the member is feeling like they're deriving value. So that's sort of the work ahead, and then building out our next ecosystem for youth, and if we get funded next year, for substance use disorder. I will say on any given day, just given the complexity and really wanting to get this to scale, the start can feel like the finish, and the finish of one thing can feel like the start of another, but it's incredibly rewarding work. And to hear from our clinician partners the value they're deriving from having these tools available to them, and from hearing from our members where the value is. But we want to go deeper on the research and begin to answer some of the questions that were asked this morning. So I'll now briefly tee up a video that the team are going to show.
How it started was I was really feeling overwhelmed, and there was a lot going on in my life at that time to where I just almost lost it. It's empowering to say, I can use this, I can ground myself, I can continue doing my activities, enjoy my life.
We're seeing early signs of good clinical improvement from people who are engaging with these apps. Digital therapeutics have a clear place in a spectrum of care that we want to deliver. What we're really tapping into there is the trust that people have for their Kaiser Permanente clinicians.
I knew patients would get better. Of course they're getting better. They're doing the work in between sessions. We're engaging together with it in the office. I'm getting them started, and they leave with the excitement and the access of these tools.
My blood pressure has gone down. My sleep has gone from like the 3 to 4, then the 5. I'm actually getting 7 to almost 8 hours a night. This is perfect for someone like me.
Thank you, Trina.
You're welcome, Bruce.
Another great presentation.
A quick drive by.
And as always, you're covering an enormous amount of ground. So I really do think you have the most comprehensive system that we've ever seen that's up and running and getting integrated with your electronic health record. Last time we talked, it wasn't quite there, but it sounds like that's getting there. So phenomenal presentation on a great system. And we're going to get through a few questions here. And if we're going to run out of time, which I think we are, if you're going to be around later,
Sure.
We'll have some more questions, maybe before Monica and I close out the session. But here's a couple of questions. Well, one question is, what are you doing with youth? And if you could just give us a thumbnail of exactly what you're looking for and what you think, what you're hoping to get in terms of the children and youth apps.
Sure. So when we looked at our data, we saw depression, anxiety, adjustment disorder, and ADHD were sort of part of the top diagnostic cluster that we also felt had a digital play. So they're kind of the main areas that we're looking at. We initially wanted to do 12 to 24, but with the COPA laws for 12-year-olds, we're 13 to 24. So we actually we're testing about 13 apps right now. It's a lot. I know it's a lot, but they're generic or general in the sense of a lot of content and some with coaching to sort of manage through that moment for young people, because you can imagine the developmental age we're dealing with and executive function, et cetera, et cetera. But we recognize youth are digital natives. So the way we've built the ecosystem in adults, we will have apps and content, but how they'll get it will be quite different because they will absolutely want to be text-based. And the content we have, they're not going to come on our website and read our wonderful content that we've built. So we're testing different ways of getting good content in their hands that's more like what they're used to seeing. So TikTokifying it and making it bite-sized. We've actually heard both from youth and parents that's how they want the information. And our ecosystem also addresses parent needs, because if we're only looking at the youth and we're not looking at the maintaining environment, we're missing half the picture. So testing a lot of different apps, different user experiences that relate to depression, anxiety, and panic disorder. Specific apps for things like that, for self-harm, for example. They're very popular with our clinicians. And what was interesting was we were giving them 3 or 4 apps at a time, and we were going to take those away and give them another 3 or 4. And the resounding feedback we got was, give us everything. Don't give us 4 now and 4 later. We want them all. We need them all. And so that has been a real learning experience for us, because we thought the cognitive burden of trying to track 13 would be difficult. So that's sort of, we're learning a lot this year to deploy, and with our young people and parents and clinicians, it's incredibly rich experience, and we really hope to stand up something that can begin to touch that burden of suffering that young people are dealing with now, because many of them don't want to go to therapy. They're like, my parents made me go. I didn't want to talk to somebody for 50 minutes that I don't know. It was hell, So we're hearing those things. So how might we meet those needs a bit differently, and then maybe create the path as a pre-therapy path? So that's sort of what we're learning early days.
Terrific. There are two related questions here. I'm going to package them all together. You have an enormous population that is stratified by, I'm sure, economic, socioeconomic issues, racial issues, and also payer kind of issues. Have you looked at user engagement for different stratification cuts through your population, both engagement and outcomes?
So that's coming next, Bruce. So that MRN level data that I talked about, being able to get at that, will enable us to look at line of business in the way that question was asked. I think the journey we're on for more the enterprise-wide solutions, we wanted to make sure we were tracking to sort of inducement issues for Medicare and Medicaid, and make sure we're compliant. But the tools are available to anybody that our therapists or clinicians feel they need them. But we haven't been able to slice the data by line of business yet, because we haven't had that granularity from the app side, and that's coming, and we will be able to do that. So we're excited to be able to do that, because we recognize that we may be really well engaging some segments and not others, and we don't want to create a situation where we're exacerbating a digital divide, for example. So that's coming.
Got it. And the value data that you're going to be looking at will, I assume, also the other costs of care, like emergency department or hospitalization, all of that, you're going to be able to mine that kind of data from your system.
Yeah, our researchers are literally chomping at the bit to get access to the MRN level data, so they can look at, because we're an integrated system, if you have diabetes and you had depression last year and you saw a therapist, how are you doing now? How are you doing the year before? And then in the future, how are you doing? Because our members tend to stay with us quite a long time. That is the intent of being able to get to that more granular data, so we can begin to mine that and understand what fits best for whom and where, because right now it's everywhere, and we're really trying to see and calibrate it the best way we can. But we are doing it with some data integrity, but we want to be able to get to the more granular data so we can answer those questions. So absolutely, to begin to understand that's the whole person care, and how these tools can possibly impact that is what we want to know the answer to.
The selection process that you outlined is really very good, I think. We've done a lot of work, and we've talked about that in terms of a large selection matrix for if you're looking for one system.
Right.
You think that's going to be the same system that you're going to use for youth? And do you think that would be something that those of us in the community system that are looking still at selection criteria could use that as a model?
We are using it for youth. I will say the youth space is even more nascent than the adult was in 2017, and I think that's still relatively nascent. So the maturity of some of these companies, they're not quite at their tallest, if you will. So that will kind of factor into their score on our framework. But I feel like we've evolved to learning through all the different dimensions of how to do this, that's reflected in our framework, and certainly could explore, if others are interested, if that could be of value to you, because your own unique market, you can weight the rubric and the components to what matters to you at that precise moment in time, and still get a score that you can work from, and then talk through the other pieces that maybe aren't as well reflected in the framework, or add them, because we keep sort of building it out and adding dimensionality as we're learning through things. So yeah, I'd be open to
that. Here's a question related to socioeconomic barriers. What do you have available as a payer and provider, or a payvider, as Monica would say? You have more available to you if you have clients who may need help accessing Wi-Fi, or with getting access to smartphones or things like that. Do you have strategies, plans? Is that systematic? Is it regional? What's the Kaiser approach to
That's
just
a
that
great
basic
question.
access to technology? Because we've
Yeah,
found
you're
that,
preempting.
I think, as you know, we found that in some of our populations here in the metro Boston area, where we're trying to get individuals who might be interested in getting on a system but don't even have a smartphone or Wi-Fi plan.
Right, right, right. Great question. And I actually did connect with our one of my colleagues over many years, Pam Schwartz, who works in our social health. She's executive director there, and really leading the programs on providing food, connecting people to, say, SNAP benefits, but part of that also housing. Part of that's also connecting people with phones and minutes so they can stay connected. And so we've been talking about how might we connect more in our work to make sure we're not missing opportunities to mind those intersections in our own system, because we're a large system, and like any large system, there can be silos of work, and we're beginning to start to think about how we make sure that's happening. I would say, our clinicians already know with those members if they have a phone, if they have, limited data plans, and that's influencing their choice in the 1-to-1 ratio. But I think we can probably do a better job of leveraging and knitting together the different initiatives that we have in our system, including our very robust social health work that's been happening all through the pandemic and beyond. So I think it's a good question, and sort of a double click back to me to connect back to that team and make sure we're not missing an opportunity in front of us to connect people to resources and leverage that phone where we're getting the phone and the minutes to be also part of access to these apps.
I'm going to put in one more question from Monica, because one more question.
Okay.
What are you considering? Are you considering the same kind of analytic framework for selection for the substance use apps or programs, which will be your next iteration, or have you gone that far yet? Is it the same selection process, you think?
It will, and it'll be a little different, because I think substance use disorder is quite different, and I think we're ready for that. So I will say that what we've done now is really leaning into psychoeducation and CBT and coaching. With the substance use disorder, you see some of that, plus you also see more of the telehealth piece too. And so I think we'll want to literally broaden the lens for substance use disorder. We're going to hear from our members and from our clinicians in addiction medicine what the needs are, and make sure we build what their needs are. So we definitely have a good foundation, but we don't want to assume that we won't need to flex a little for that patient population. So I think we'll need a broader set of lenses, because the kinds of tools that are out there are a little different to maybe some of the mindfulness meditation tools. If I can there's just different flavors. It's all ice cream, right? But it's different flavors, and we want to make sure that we're mapping the right tool for the right level of patient care. And that's the journey ahead of us. So we've submitted the business plan for it to do that exploratory work in 2023. And we keep the funnel broad until we've to narrow. That's sort of our philosophy, so we can learn and make sure where we're going is pulling from the demand from our members and what they're looking for, and from our clinicians and saying what they need in their toolbox. So that always drives what we do.
One just quick question: the Digital Therapeutic Alliance is the new guide that you reference. Is that the entity?
Yes.
Digital Therapeutic Alliance.
Yeah.
So people I
can give you the link in our chat, and then the team can put it out there if they want to see where it is. But yeah, that's a very robust guide that had a tiny little part in shaping, but a lot of the dimensions you see in our framework are reflected there, and then some. So it is a nice starting point if you're just not sure. It really pulls in a lot of things that healthcare decision makers think about day to day. And then, of course, you customize it for your own local area as well. So it takes some of the brain cycles out of the equation that you need to go through, because you can just start there.
Thank you so much, Trina. Another terrific presentation. And if you're around at the end, we may have a few more questions.